you very much. It's my pleasure to be in your conference. My name is Matineh Nirouei. I'm graduated with a MD degree in 2021. Now I work as a family physician in healthcare centers. I published more than 10 research articles, and I am passionate about learning new scientific skills. I'm going to talk about case of pregnant woman with a severe thrombocytopenia and lupus. I'm going to talk about this case in 6 main titles. Introduction, I'm going to introduce the hard and complicated situation that we face. And then I'm talking about case presentation. And then I'm going to talk about the treatment that we used and the follow-up and outcome that we had. And at the end, I'm going to discuss the treatment options. And in the conclusion, I'm going to conclude the case. Systemic lupus erythematosus, or SLE, is a multiple system disease that characterized by loss of self-tolerance, which leads to the activation of B and T cells, and in turn, the production of pathogenic autoantibodies, and subsequently, tissue injuries. 90% of lupus patients are women who are in their reproductive ages. So the management of lupus in pregnant women is a very important point for obstetricians. Pregnant women who have a history of lupus are in the higher risk pregnancy in comparison with normal population. They have a higher risk of maternal and fetal mortality and morbidity rates. Some complications that I want to include here in pregnant women with a history of lupus are fetal demise, hypertensive disease, and thromboembolism, and fetal growth restriction, and premature delivery and neonatal deaths. So it is very important to manage these, to manage the lupus during pregnancy. Something that I want to talk about here, lupus treatment, SLE treatment, has more complication during pregnancy, more than SLE, the disease itself. So the treatment is very important in pregnancy. I'm going to talk about the case that we had. We had a 41-year-old Iranian woman who was at the gestational age of 32 weeks. She referred to our tertiary hospital due to rupture of membranes and decreased platelet counts and severe pitting edema in her legs, feet, and ankles. She had a history of lupus. She was diagnosed at 37 years of age. At that time, she presented with spontaneous petechial rashes and arthralgia. And after diagnostic tests that done in that time, she diagnosed SLE, lupus. Following that, she didn't have any lupus flares up, and she had been taking azathioprine, prednisolone, hydroxychloroquine to control her disease. And she never discontinued her medication during these years. As a treatment, we started magnesium sulfate to delay the labor, and we administered also 2 doses of betamethasone during the first 48 hours. And we added ampicillin and erythromycin for infection prophylaxis. and hydroxychloroquine and azathioprine and prednisolone to control her lupus flares. She had flare up of lupus symptoms like paresthesia, gingival hemorrhage, musculoskeletal pain, and severe swelling in her legs and feet. After we added this treatment regimen, her platelet count, the first day that we met the patient, was 9,300. After this administrated regimen, her platelet count reduced to 8,000. So we added IVIG to her treatment regimen because she didn't respond to prednisolone regimen. After 1 day that we started this regimen, she reported that she had reduced fetal movement and decreased fetal heart rate and non-reactive NSD. She was candidated for emergency cesarean section. In the delivery, during the delivery surgery, cesarean section, we found the placental abruption and postpartum hemorrhage. So we fixed balloon and rectal misoprostol as a treatment. When she went to delivery room, she had platelet count 20,200. It was really, really thrombocytopenic. After 13 days of she had delivered a preterm baby girl with 2,200 grams and with Apgar 3, 7, and 9. Her baby resuscitated, and because of respiratory distress syndrome, she's sent to NICU. In the follow-up and outcomes of our patient, after 13 days of hospitalization, our patient was discharged, her pitting edema was resolved, and her platelet counts had risen into the normal range, 278,000. She had no problem with breastfeeding her child, and she was asked to come to the clinic after 1 week for follow-up. Her first follow-up visit showed an improved general condition and no sign of infection of the incision site, and her platelet counts were within the normal ranges. Pregnancy in patients with lupus creates a very dangerous situation for mother and fetus because lupus causes maternal death, preeclampsia, preterm labor, thrombosis, infection, and hematologic complications during pregnancy. So managing this patient can be challenging for specialists because they have to create a balance between the mother's treatment and fetal health. The most challenging aspect of treatment lupus during pregnancy is choosing the best medication to treat the mother and also thinking about the fact that those medications could be harmful for the baby. Lupus treatment regimen in pregnancy mostly consists of hydroxychloroquine, low dose of steroids, azathioprine, and in patients with antiphospholipid antibodies, low dose aspirin with or without low molecular weight heparin. Corticosteroids are the main medication used in lupus and are also considered safe during pregnancy. However, use of high doses of corticosteroids during pregnancy is not recommended because it might increase the risk of complications like diabetes, hypertension, preeclampsia, and premature rupture of membranes. Hydroxychloroquine should be continued during pregnancy in all patients with lupus because discontinuation of this drug leads to flares. Most immunosuppressant agents are contraindicated during pregnancy, but if lupus is in the active phase, Azathioprine is considered as a safe drug. During the first and second trimester, NSAIDs are considered safe medication with no documented increased risk of congenital malformations. Use of antiplatelet agents during pregnancy is only advised when the maternal benefit clearly outweighs the potential fetal risk. In the conclusion, in this study, we described a 41-year-old pregnant woman with a history of lupus who referred to our hospital due to rupture of membranes at the gestation of age of 37 weeks. On laboratory workup, she was found to be severely thrombocytopenic, which was later found to be unresponsiveness to prednisolone. Therefore, we added IVIG to her treatment regimen. On the day of 3 of hospitalization, due to decrease of fetal movement, increase of fetal heart rate, and non-reactive NSD, the patient became a candidate for emergency cesarean section under general anesthesia with a platelet count of 20,000 and 20,000. Since her thrombocytopenia didn't respond to prednisolone and IVIG, so we administered 5 units of platelet before delivery. During the surgery, placenta abruption was detected and postpartum hemorrhage ensued. Consequently, a Bakri balloon was fixed and rectal misoprostol was administered. After cesarean section, she was admitted to the ICU for further medical treatment and supervision. Thank you very much for your attention.